vaccinations during this COVID time. And for this, we have the next session. It's my pleasure to introduce the chairpersons, Professor Vikas Suri, who is Professor of Medicine at PGI Chandigarh and has a special interest in infectious disease. Dr. Sanjay Chandani, who is Assistant Professor at BYL Nair Hospital in Mumbai, and Dr. Akash Mathur, who is an Assistant Professor at Sanjay Gandhi PGI in Lucknow. Over to you, chairpersons.
Hi, good evening. It's a great pleasure and a great big thank you to the organizing for giving us an opportunity to be associated with this great endeavor. Let me introduce Professor Francis. He's a professor of medicine and in charge of the IBD Center at Mayo Clinic. And he'll be talking about vaccinations for the patients with IBD. Over to you, sir.
Hopefully you can see my screen. Thank you very much for the opportunity to speak today. This is an area that I've been looking at for close to 11 years now and near and dear to my heart. These are my disclosures, and these are our objectives: to appreciate the increased risk of infections in patients with inflammatory bowel disease, review necessary vaccinations for patients with IBD, and how we can use checklists to improve vaccination rates. So what are the benefits of vaccination? I don't need to tell a group of physicians how important vaccinations are. The first influenza vaccine was licensed in the United States in 1945. If we look at flu vaccination in 2017 to 2018, it prevented 6.2 million cases of the influenza and 5,700 flu-related deaths. Measles, mumps, rubella was licensed in 1971. This vaccine induces 94 to 96% immunity. Prior to vaccination, measles killed an estimated 2.6 million people per year worldwide. And unfortunately, even in 2018, there were 140,000 deaths worldwide from measles in parts of the world that did not have access to vaccination. Gardasil, the HPV vaccine, was licensed in the United States in 2006. It is available in India. HPV infections were reduced by 86% in vaccinated teenage girls, and 90% of the 35,000 HPV cancers can be prevented if all at-risk individuals were vaccinated. The return on investment for the dollars you put in to vaccinate individuals, 44 times estimated return on investment. And then finally, only clean water rivals vaccination in its ability to save lives. So let's talk about health maintenance in patients with inflammatory bowel disease. We know, at least in the United States, that patients with IBD do not receive preventive services at the same rate as general medical patients. In the United States, individuals with IBD often see their GI, MD, or nurse practitioner as their only primary clinician, and we as specialists need to clarify the limits of our responsibilities with the patient. I certainly take care of vaccinations, but I delegate routine healthcare issues like checking cholesterol and things of that nature to their primary care team. But if we're going to delegate some responsibility, we have to realize we have to help the primary care provider understand the unique needs of patients with IBD. And I would argue, and in our practice, and more frequently here in the United States, certain healthcare tasks, such as vaccinations, are indeed the responsibility of the treating gastroenterologist who's using tofacitinib or a biologic agent to treat their patient with IBD. So why are these initial visits when seeing a brand new IBD patient so important? Well, we know that as many as 70% of patients with IBD will require immunosuppressive therapy at some time in their course. Consequently, those early visits before they're immunocompromised are the best times to catch up on their vaccinations. Now, we know that immunomodulators and biologic use to treat IBD put our patients at increased risk for infections. We just heard a very interesting and informative lecture regarding exacerbation or reactivation of TB in patients receiving these agents. There have been multiple case reports of infections, including fulminant hepatitis, fatal varicella. And we do know that this risk of infection increases with the number of immunosuppressive therapies, steroids and thiopurine, steroids and anti-TNF. So if you're on 2, it's worse than 1, and 3 is worse than 2. Several, but not all of these are vaccine preventable. And at least in the United States, we're seeing more and more importance placed on vaccinations. And in my referral practice 10 years ago, we would rarely see notes where people, the referring doctor is talking about giving pneumococcal vaccine or zoster vaccine, and we're seeing much more of that in our referring notes. Now, this is a question that I typically ask the fellows, and they would typically say tuberculosis. Maybe in India, tuberculosis, but in the United States, what's the most common infection? And the most common infection is pneumococcal pneumonia, and we can prevent pneumococcal pneumonia with appropriate vaccination. This is data from Millie Long. I'm going to show you information on pneumonia and then information on zoster. This is a large administrative database that they can look at, and they looked at the risk of developing pneumonia in 108,000 individuals with IBD. And you can see the adjusted odds ratio was 1.32 for biologics, 1.13 for thiopurines. And as we just heard from Dr. Deepak, again, steroids being an important risk factor for pneumonia and COVID. And if we just kind of look at the annual pneumonia incidence in patients with IBD, you can see the overall IIR was 1.82. Now, if we want to look at zoster in that same administrative database, you can see the increased risk of developing zoster based on biologic use, thiopurine or corticosteroids. But look here, the combination of an anti-TNF and thiopurines, the odd ratio of developing zoster was 3.29. So very, very significant. So when's the best time to identify and vaccinate? Well, clearly during those initial office visits, as I mentioned earlier, before the patient starts immunosuppressive therapy. We have the luxury here at Mayo. I work on the 6th floor. I can send patients down to the 4th floor after their office visit and get vaccinated. But in parts of the United States, which are small practices, what we recommend is that the clinician just write a prescription and they can send it to their local pharmacy, and the patient can get their vaccination at the local pharmacy. An issue that often comes up is we now identify that someone needs to receive a vaccine. So let's say measles, mumps, rubella, and now they're in the throes of an acute episode of ulcerative colitis. We clearly need to treat their IBD and deal with the vaccinations at a later date. So I've hopefully shown you that patients with inflammatory bowel disease are an increased risk for vaccine preventable diseases. And now we're going to walk through some of the ways that you could use information that's published in the literature to get your patients vaccinated. So I was very, very fortunate to work with Gil Melmed from Cedars-Sinai, Gary Lichtenstein from Penn, and Susie Kane from Mayo in Rochester to put together this review for the American College of Gastroenterology that was published in January 2017. Also of note, this is the ECHO consensus paper that was just published. I was fortunate enough to be one of the American authors on this, on the prevention, diagnosis, and management of infections in patients with IBD. And then every year in February or March, the ACIP and CDC publishes their recommended immunization schedule. So for individuals in the United States, IBD is rare before the age of 5. So most patients should have received all their childhood vaccinations. I see patients 16 and above in my practice. So the vaccines we need to think about would be hepatitis A, hepatitis B, HPV, influenza, pneumococcal vaccine, zoster, and then chickenpox or varicella. Now, a question that typically comes up is, well, I'm already immunosuppressed. Will the vaccine work? And we've seen this with COVID. We've seen this with influenza. We've seen this with other vaccines, that there's a diminished immune response to these parenteral vaccines in patients on anti-TNFs alone, in particular, the combination of anti-TNFs and immunomodulators, but we don't seem to be seeing a decrease in immune response with vedolizumab or ustekinumab. Now, the other question that typically comes up from patients is, I have an autoimmune disease and you're giving me a vaccine. Isn't that going to stimulate my immune system and make my IBD worse? And there's really no evidence that vaccination exacerbates IBD. This was something that was just published in the IBD journal. One of my colleagues from Massachusetts did a systematic review and meta-analysis. And the bottom line, you can look at this, is that the risk of adverse events is similar to those reported in non-IBD patients. And the risk for exacerbation of IBD was 2% with confidence intervals of 1.4%, which tracks with the background risk of developing an exacerbation. And again, we are now seeing a number of studies coming out looking at de novo IBD after COVID vaccine. We have a paper that was just published in Alimentary Pharmacology and Therapeutics, literally 4 or 5 days ago, that showed no increased risk of developing de novo IBD after vaccination. And I think the general consensus is that there's no exacerbation of IBD after vaccination, for COVID, that is. Now, this is a vaccine that I don't think is available yet in India, but I wanted to tell you about it. This is called Heplisave, and it's approved in the United States in 2017. And what's really nice about this, compared to the standard 3-dose vaccination, it's 2 doses given 1 month apart. So you could vaccinate and basically protect patients at high risk over a shorter period of time. And in non-IBD patients, in a head-to-head study, you can see seroprotection after 2 doses of this vaccine, which has an adjuvant, was 95.4% versus 81.3% in the 3-dose vaccine. There's some background incidents of immune-mediated adverse events, but they were about the same. So it does not seem that the adjuvant is leading to an increased risk of immune adverse events. And it's included in the ACIP recommendations. And there were no studies in IBD until we did our study. We now have 104 or 106 patients at the Mayo sites who received this vaccine for individuals who were not, who had not responded or had actually had negative antibody titers to hepatitis B. And these were all individuals with IBD who might be starting anti-TNFs or other therapies. And what we saw, at least in the pilot, was that 89% of individuals who had not been protected are now protected. So this is the vaccine we preferentially use in at Mayo, at all the Mayo sites. And again, patients on more immunosuppressive therapy had lower seroconversion rates. A real advance in preventing herpes zoster was the release of the inactive Shingrix vaccine. This is a vaccine that's given 2 doses at 0 and then 2 to 6 months. It's highly effective. About a quarter of people will have significant myalgias, headaches, you know, those kind of things. And I recommend patients get the vaccine like on a Saturday morning or a Friday night when they don't have anything important. And the ACIP recommended, given the short protection from Zostavax, the live vaccine, they recommend that even if you had the live vaccine, you should get Shingrix. And similarly, if you had shingles, you should get Shingrix. And then finally, the Zostavax is no longer available in the United States, and it is available still in India. We'll talk about that. So the new recommendations from the FDA, they came out in 2021, July, and now it's basically saying that immunocompromised individuals, so our patients with ulcerative colitis or Crohn's disease who are immunocompromised, now are eligible to receive the Shingrix vaccine. It's actually 19 and above. So either if you're on an immunosuppressive therapy, or hypothetically, if you're a Crohn's patient or an ulcerative colitis patient who has a 70% chance of needing immunosuppressive therapy, you can vaccinate them. And again, we're now working through this through insurance to see if they'll start paying for patients 19 and above. And what's also interesting, compared to the 0 and 2 to 6 months, it's now you can now give this 0 and 1 month. So you don't have to wait the as long as 6 months for those people at risk. We did a study here looking at this data set called the Explorers data set, and we showed that receipt of the vaccine resulted in a significantly lower rate of herpes zoster in patients with IBD. So the odds ratio was 0.36. And then a study from the VA of 7,000 patients also demonstrated receiving RZV or Shingrix was associated with a lower risk of developing shingles. But both studies showed a very, very low rate of vaccination. So this is something we need to do and make sure we vaccinate against zoster for our at-risk patients. Now, I want to contrast high-level immunosuppression and low-level immunosuppression. This is important if you only have access to Zostavax, let's say in India, though I understand you can get Shingrix in India, correct me if I'm wrong. And what's basically we have to realize is that there's low-level immunosuppression, so that would be methotrexate, azathioprine, 6-MP, and then high-level immunosuppression. And we've done some work, and the CDC has basically said that it's safe to administer the live zoster vaccine, Zostavax, in patients with low-level immunosuppression. So even though it's a live vaccine, if it's the only thing you have, it is safe to administer. And there are data now even showing that it's safe to administer in patients who are on anti-TNFs. This comes from every year in February. This comes from the ACIP, and it looks at recommended vaccines based on age. And then it basically breaks it down to immune compromising conditions. And this is the one we'd be interested in, immune compromising, excluding HIV infection. And then if we drill down to it, it says, and I'll go over this in subsequent slides, that the live influenza nasal vaccine is not recommended for our immune compromised patients with Crohn's disease, measles, mumps, and rubella, and the chickenpox vaccine would not be recommended. The Shingrix is recommended, HPV is recommended. Remember, the only 3 live vaccines we're dealing with are this. Now, I apologize, for some reason I could not get this off the website. This is from adult immunizations based on medical and other conditions in India. And this box here is similar to the box that I just showed you here. So this is based on the CDC and ACIP recommendation. And just as previously, the varicella, and this is the live zoster vaccine, measles, mumps, and rubella would not be recommended in IBD patients who are immunocompromised. Though again, I've just told you, you can probably give Zostavax if that's the only vaccine you have. And this goes over the ages at which you would give it. So if I were to summarize the vaccines, looking at immunocompromised and immunocompetent patients, everyone should get the yearly influenza vaccine. The live intranasal vaccine is not recommended for individuals who are immunocompromised. Tdap or TD booster every 10 years. Again, measles, mumps, and rubella, varicella, chickenpox not recommended in immunocompromised patients, but can be given to those who are immunocompetent. This is the new recommendation that if you are immunocompromised 19 and above, you can receive 2 doses of the Shingrix vaccine, the inactive vaccine, 18 and above. But if you are immunocompetent, it's recommended for above the age of 50. So for the most part, all our IBD patients would be here. HPV vaccine in the United States, 9 through 26, if not previously immunized, and have a discussion with the individual about 27 to 45. I know that Pneumovax is available in India. I don't see Prevnar being available, at least from a search last night. And I'll show you on the next slide the way you use both Prevnar or PCV13 and Pneumovax. And then hepatitis A and hepatitis B, we've already gone over the fact that in the United States, we're using Heplisave given the higher efficacy. And this would be a reference for you, the order in which you give the pneumococcal vaccine series. You do need to do them in a specific order. I won't go through them for time, but this would be available to you. So a couple of vaccine hints. When COVID vaccine first came out, it was recommended to give the COVID vaccine alone because we really didn't want to mix and be confused by adverse events that might be associated with COVID vaccine versus other, but that has now been basically taken away. And so you can give the COVID vaccine and the influenza vaccine if you want. The only exception, again, is you have to give Prevnar and Pneumovax separately. Again, all vaccines can be given during one office visit. Don't put them off just because someone's behind, try to catch up. And again, all live vaccines can also be given at the same visit. These are a number of references of papers that I've been involved with in terms of vaccination. This is specifically in IBD. This was a paper in the journal Vaccine talking about the importance of us as specialists working with the primary care doctor to improve vaccination rates. This comes from Cornerstones from Marla Dubinsky and David Rubin. It's a very, very helpful checklist. This goes over vaccines, bone health, therapy-related testing, for example, measuring lipids in patients on TOFA, cancer prevention, other things. And this is the drill down looking at all the vaccines. Now, the Crohn's and Colitis Foundation also has a checklist. This is the checklist for adult patients. And again, these slides should be made available to you. This is the checklist for pediatric patients. So I'm going to leave you with a number of take-home points. Patients with IBD have poor immunization rates, so ask about vaccination status. We are doing better. When possible, vaccinate prior to initiation of immunosuppressive agents. You clearly have seen this over and over again, that multiple immunosuppressive therapies are going to decrease the immune response. And again, we don't know whether a decreased immune response translates into increased risk. For example, in the COVID studies, the antibody titers are still above the threshold of protection, but lower than in healthy controls. And the big concern, as pointed out by the earlier presenter, is really the way the antibody titers will drop over time if you already have a lower immune response. Multiple vaccines can be co-administered safely. Patients with IBD can mount a response to vaccines, again, though immunogenicity is decreased. Reassure your patients that disease activity will not be affected by vaccination, including the COVID vaccines. Encourage all your patients to get vaccinated, including COVID. We do this in our office. We have the luxury to do so, but if you can't, at least here in the United States, patients can go to their local pharmacy. And I'll show you my button that I wear when I'm seeing patients, and I'm a real advocate. And we do advocate, at least at our facility here in Mayo, Florida, vaccination is mandated for all employees for both influenza as well as COVID. And this is my little button that I wear on my lab coat and on my sports coat, so patients really know where I'm coming from. And like many of us, we all have our pictures of our 2 vaccines. I did get boosted myself. And thank you very much, and I'm happy to take questions.
Thank you so much, Dr. Francis. I have one question for you. Suppose that if patients developing IBD have received vaccines in childhood, which is very common in India, such as MMR vaccine, do they need an additional shot or some other shot before starting some immunosuppressive therapy? Any recommendations on that?
Yeah, so it's really important that the commercially available antibody tests that are, at least in the United States and presumably in India, they have a low sensitivity for detection of antibodies. So if someone tells us they received measles, mumps, and rubella as a child vaccination, we do not check titers and we assume they're protected. So I would recommend that you don't check titers if you can have a documentation that they received. Similarly, for chickenpox, if someone tells us that they've had chickenpox, so in the United States, if you're above the age of 40, there's a 98% chance you had chickenpox. In fact, my parents took me to a chickenpox party. That was something that was really big way back then when I was 4 or 5, to give me chickenpox when I was a little boy. So if you have a history of chickenpox, there's no reason to check varicella serology to decide if you need a chickenpox vaccine, but more importantly, the CDC does not recommend checking varicella antibodies. You just give Shingrix because you assume that those individuals were exposed if they're older. And if they're younger, even if you receive varicella, there is a vaccine. There is a very small risk of developing shingles, even if you were vaccinated against chickenpox. So those individuals, if they're immunocompromised, are also eligible to receive Shingrix.
Such a wonderful talk, and for a country like India, where we have a real unmet need of adult immunization, especially in patients with IBD. I think this was a brilliant illustration of what needs to be done. The question I have here is that while advising vaccines to our patients with IBD, are there any other specific factors which one needs to be wary of, like disease activity, patient's nutritional status, other comorbidities, etc.?
Yeah, very good, because this is a big issue. Again, do you wait in between, let's say, the interval of every 8 weeks before giving the COVID vaccine? And when COVID vaccine was scarce rather, we basically said, get it whenever you can. I'm in favor of the adage of strike while the iron is hot. At least that's something we say here in America. Don't know if you say that in India, but the point is that if you have a patient, give it to them whenever they can, whenever they're there. There's one study that looked at influenza vaccine relative to an infusion of infliximab and showed that it did not make a difference whether you got it on the day you received infliximab or weeks later. So if you have an opportunity to give the vaccine, just give the vaccine regardless of where they are on their medication. We do not recommend the rheumatologist initially recommended to hold tofacitinib or methotrexate for a week or two before giving the COVID vaccine. I don't believe that has finally been translated into their final recommendations. And was there a second question? I'm sorry.
No, I think you have answered all the queries.
And then this is what I found, and I apologize. I think the Indian government does not want me to see what you're recommending, but you probably have a better access. And it does show that you have access to HPV, varicella, zoster, but I think this is the Zostavax, measles, mumps, rubella, influenza, only the pneumococcal polysaccharide, which is PPSV23. I don't know if you have Prevnar available in India.
Hi, good evening, sir. So it was a very nice presentation. We have a question in the chat box. This is from Miss Tina. So she says that what happens if the patient on IMM doesn't have titers to measles or mumps, but has received MMR vaccine as a child. So her question is that if we have demonstrated that we don't have antibody titers to measles and mumps, and the patient is on immunomodulators, should we go for the live vaccine during the treatment?
So again, getting back to the previous question, if you document that child received the 2 doses, and I believe it's 2 doses in India, of the measles, mumps, and rubella, then assume they're protected. I would not check their antibody titers because it creates this type of quandary of negative antibodies when we know that the blood test to detect antibodies can be falsely negative. So I would not test the antibodies if you knew the patient was vaccinated. Now, if you did not know the patient was vaccinated, you're in a quandary because giving the measles, mumps, and rubella vaccine is contraindicated if they're immunosuppressed. So you're basically in a situation where you can't vaccinate them. And if they're sick from their IBD, you just have to treat their IBD. We sometimes, if the patient was on, and again, this is clearly something you'd have to discuss with your infectious disease experts. If the patient, we know that for zoster, live zoster vaccine, it's safe for people on immunomodulators monotherapy, and it's safe for people on anti-TNF monotherapy. You could, with input from infectious disease and full approval of the patient, potentially give them, if it was just, let's say, the mumps antibody that was negative, a mumps vaccine. But in general, I would say that the risk outweigh the benefits, and I would not vaccinate that individual.
I have 2 questions and a comment. Well, the pneumococcal vaccine, both the 23 and the 13 valent are available in India. We don't have the Shingrix and the recombinant hepatitis B. The GISI is planning to come out with paper, the recommendations on vaccinations and IBD in adults soon. And my question to you is there do you recommend double dose or a change in the dose in patients who are on active immunosuppressants in patients with IBD, especially hepatitis A and influenza vaccine. There is some data for double dose of influenza vaccine who are in patients who are on immunosuppressants.
Yeah, very good question. In the United States, the high dose influenza vaccine is recommended for individuals 65 and above. And my collaborator, Dr. Freddie Caldera from Wisconsin, has published a paper that shows that the high dose influenza vaccine is more effective in people that are on anti-TNFs. So if you had an immunocompromised individual and influenza season is beginning, I would administer the high dose influenza vaccine. The only data we have is for anti-TNF patients. In terms, the second question, of double dose. So if you do not have access to the Heplisave, the adjuvanted vaccine, and you have a patient who's at risk for acquisition of hepatitis B, let's say they received childhood vaccination, but they have non-detectable titers, I would give a single dose of Endurex and then measure their antibody titer 4 weeks later. In many of those individuals, you'll have an amnestic response and they'll seroconvert. But if they don't seroconvert, then I would give them double dose of the standard vaccine. And the individuals that are less likely to seroconvert are older, above the age of 40, chronic kidney disease, and COPD. But we don't have too many patients with IBD that are going to have COPD or chronic kidney disease. But clearly, the older you get, the less robust the response. Though Shingrix, which is an amazing vaccine because it has 97% effectiveness in basically otherwise healthy individuals, and that response seems to last for at least 8 years, unlike the Zostavax, where you see a decrease in protection after 3 or 4 years.
Well, thank you, sir. The time is over. I hand it back to Dr. Vishal, and thank you very much, sir.
Thank you.
It was a great pleasure listening to Dr. Farraye and his extensive experience in the field of vaccinations in inflammatory bowel disease. And in fact, I hope that we can count on him to guide, the guidelines which we are planning for the Indian IBD patients on behalf of the Gastrointestinal Infection Society. In fact, we are planning multiple systematic reviews, and we really hope that we can, use his extensive experience to have a vaccination program for our patients in India. Thank you, Dr. Farraye, and thank you, chairpersons, for this very, very important session. Now we come to the end of this second webinar, which was organized by Gastrointestinal Infection Society of India and supported by the South Asian IBD Alliance, led by Ms. Tina Omprakash and Dr. Deepak Parakkal. I would like to thank the speakers, Dr. Sumit Bhatia, Dr. Shinoy, Professor Binsi Abraham, Professor Vineet Ahuja, Dr. Deepak Parakkal, and Professor Francis Farraye, who took time out of their busy schedule to be here today and talk to us. I'd like to thank the chairpersons who ensured that the sessions were in time and also ensured that all the questions that were put would be taken up and addressed. I'd also like to thank the support from the Department of Gastroenterology, led by Professor Usha Datta, and also by my colleagues, Dr. Anupam and Dr. Anurag Jaina, who helped in conducting and organizing this webinar. Finally, I'd like to thank our sponsors, Takeda, Janssen Immunology, and Ferring Pharmaceuticals, who have provided educational support for the conduct of this webinar. I'd like to conclude this webinar with one announcement that the next or the third GISI webinar will be on 5th of March in the field of pancreatic infections and infected pancreatic necrosis. And the organizer for that will be Dr. Jimil Shah, who is the Assistant Professor of Gastroenterology at Department of Gastroenterology, PGI Chandigarh. Thank you all for your participation, and we look forward to seeing you again for the next webinar.